Hello and welcome to today's event, our live webinar on nurse wellbeing in a COVID-19 world. My name is Steve Ford and I'm the editor of Nursing Times. First of all, I hope you are well and that you can see and hear us all right. So, why are we here today? Well, as you know, nursing staff were already under pressure before coronavirus arrived earlier this year, as they always are. But COVID-19 has obviously taken this to a new level, with emerging evidence suggesting that nurse mental health and wellbeing has been significantly affected during the initial peak, and that's before we know what we are going to be facing in the next few months. So, Nursing Times, in partnership with Vocera Communications, is asking how can nurse wellbeing be better supported, and also what is the role for technology in all this? In a minute, you'll be hearing some short presentations from our fabulous panel of speakers, after which I'll ask some questions. For example, we will explore what are the key challenges around nurse wellbeing? What could and should be done to better support the mental health of nurses? And how can technology help support nurse wellbeing and improve resilience? After that, I'll be putting your questions to the panel. So please send me your questions whenever you think of them using the Q&A button that you should be able to see on your screen. We've got around 45 minutes. So without further ado, I'll introduce our panel. We are delighted to welcome Kathryn Halford, Deputy Chief Executive and Chief Nurse at Barking, Havering and Redbridge University Hospitals NHS Trust in London. We also have Cathy Armstrong, Senior Project Nurse at South Eastern Health and Social Care Trust in Belfast. And bringing a global perspective is Rhonda Collins, Chief Nursing Officer at Vocera Communications. So first to speak is Kathryn. So welcome, Kathryn.
Good afternoon. I thought I'd start by telling you a bit about my story, really, and my experience. I work in a trust where we have about 1,000 beds and about 10,000 staff. We're just on the outskirts of London, and so we were very much involved in the very rapid rise of patients that were presenting to us with COVID. We thought we would get patients, we thought that the patients would arrive, but we had no idea how quickly they would arrive. We went from having 3 patients with COVID in the organisation to having 3 wards of patients with COVID within 10 days. We went from an ITU of 30 beds to an ITU of 125 beds. All of this caused huge levels of anxiety for our staff, particularly as lots of the patients that came in those initial weeks died and died very quickly. So as a chief nurse, what did I need to do to support my staff? So very quickly, life in the hospital became very different. So we moved to a command and control structure. So we had daily gold meetings, and myself, the Chief Operating Officer, and the medical director met at least once a day, if not twice a day, with the Silver Command team to make decisions about how we were going to run our hospital differently and how we were going to ensure that not only were the patients being nursed safely, but also that the staff were being well looked after. It was so quick in terms of the changes every day that we had to have a sit rep which we updated at least once a day. And on that sit rep, we did things like how much oxygen were we using, how many patients were on oxygen, what were their news scores, so that we knew about the severity of the patients. So normally we would have perhaps about 50 or 60 patients on oxygen. We got up to 285 patients on oxygen, and like lots of organisations, we nearly ran out of oxygen. So did I ever think I would need to know about how oxygen is piped into a hospital? Absolutely not. I can't tell you what I know about oxygen now and how it gets into a hospital. It is really, really a skill that I was very grateful that I've got, but I hope I never have to use again. We have Vital Pack in our organisation, so we're able to monitor the number of very sick patients that we have in our organisation. And we had at one point, for those of you who are familiar with the news score, anything over 4 is quite high. We had 100 people who had a news score of over 7. They were really, really sick patients in the organisation. We couldn't do electronic briefings because our digital platform is very poor in this organisation, although I have to say that we've probably achieved more in the last 6 months than we plan to achieve in the next 3 years, which is very good. And probably one of the reasons I can speak to you today is because of COVID, because I'm quite sure trying to get onto Teams prior to that would have been a near impossible task. So I am very grateful for COVID for that. So we had to think about different ways of briefing our staff. So we had a daily communications bulletin. So that came out every day. People knew it came out between 2 and 3, and it came out after goal, so we could rapidly tell people about the changes that were happening. We're a 2-site hospital, and I felt it was really important to keep engaged with my frontline nurses. I meet with my senior nurses every Tuesday afternoon, and we moved from Tuesdays to Tuesdays and Thursdays. We moved from having our meetings inside the hospital to being in the car parks and being in the lavender garden. You probably remember we had very good weather during lockdown, which was jolly helpful. So we only had to go out in our coats once. The rest of the time we were fine because of the weather. And actually it was quite nice for people because we were out in the fresh air, and lots of people were getting very little fresh air. We did move our Teams meetings to Microsoft, so we did do that quickly, and that's something that we wouldn't have been able to achieve. So we have been able to improve our digital platform, and lots of people are now able to work at home because of that. We felt it was important not only to brief our staff, but also to brief our stakeholders. So we had regular meetings as an executive team with the MPs, with the CQC. Very important for us to be assuring those people that we were still maintaining very safe levels of nursing care and care to our patients. And our NEDs, of course, our non-executive directors, they were not coming on site because at that time everybody was told not to come on site. Then our workforce. We have a very big workforce, but it very rapidly decreased by 25%. So that is a lot of people to be without in a workforce very quickly. And as we were monitoring it day by day, it was going up 1 or 2% every single day, and across the whole workforce. So it wasn't just nurses, it was the medical staff, it was the support staff as well. So we moved to a very different way of managing our workforce. We developed a workforce hub, so all of our workforce was deployed from there to ensure that everybody was safe. And we used our vital pack data to see where our sick patients were and to make sure that we had the most skilled and most qualified staff looking after those patients. So we moved them around all of the time. Of course, like many organisations, and most organisations, we had very few outpatients clinics. We had quite a few that moved to the private sector and the staff went with them, but a lot of outpatient clinics were not running. So we pulled all of those nurses into our Helping Hands team. So we had 60 nurses who we could deploy at a moment's notice to a specific particular area. And that our staff found really helpful. So if you suddenly had a deterioration in your staff, in your patients, and you needed extra staff, we were able to deploy them very, very quickly. Of course, we had to deploy people into our ITU. You can't go from 30 beds to 125 beds and not expect to change the workforce. So we did change the workforce. We went to a model which was recommended, which was team nursing. So we had an experienced intensive care nurse leading a team of nurses. Not only nurses, actually, we had physiotherapists in there, and they had a great time doing something really, really different and making a real impact. And their view of how to nurse patients and what we could do for patients was really, really helpful. We also are part of an international project looking at how the impact of redeployment on our nursing staff, and we're just waiting for the results of that. Lots of our students, of course, like many students across the country, were not able to continue their placements. We recruited them into our healthcare workforce. We maintained their education in conjunction with the universities, and most of them have now decided to join us. In fact, lots of local people who are training a long way from us chose to come and work for us during this period of time, and they've now decided to come and stay with us as our workforce of the future. So we're really pleased about that. I talked about the anxiety at the very beginning. We had really rapid deaths. We had shifts, 6 deaths a shift. We had the gynae ward that suddenly became a medical ward that had 3 deaths on the first day it had looked after males ever. This was really difficult for staff, and people were dying really, really quickly. And of course, relatives couldn't get into the hospital either because they couldn't travel because they were too far away, or because in those first few weeks we were unable to let people into the hospital. We had people, our staff, on FaceTime talking to relatives, saying goodbye. That's really tough, and that's really hard for staff, and we are still dealing with the outcome of that now. We had lots of wobble rooms and lots of wellbeing rooms, like lots of organisations, but unlike lots of organisations, we've worked with our charities and we're now building those into permanent features for our staff. We also had lots of psychologists on site. It was really tough for people. But we tried to celebrate as well. So we have a tree of life in both of our atriums, where every patient that goes home is able to put a bumblebee on the tree. And for us, that represents all the people that went home. And for our staff, that's very powerful, because for those people who are looking after people who are dying, intensive cares and that sort of places, it's really good. It looks like we've got a great big swarm of bumblebees over both of the trees, but it does demonstrate that although 447 people died, over 800 people went home and are continuing to go home. We also had been making a programme with the BBC prior to COVID, and that aired during COVID, and that was really nice for staff to see. And we spent a long time celebrating International Year of the Nurse. And our final bit of technology, which we would never have believed that we could have done, was we held an annual conference, and we held it virtually this year, which was just really great. And lots more people could access it because of that. So we learned a lot. We're preparing for the next wave, and we're fairly confident the next wave is just here now. But I am worried about how people are going to be able to respond. I'm really worried about how people will be tired. But I would just like to say that I couldn't have been a chief nurse leading this without my team. They were absolutely great. Thank you.
Fantastic. Thank you very much, Kathryn. I particularly love the trees and bees. That's brilliant. Okay, and next to speak is Cathy. Our planned speaker with Roisin Devlin has unfortunately had to drop out, but Cathy has kindly recorded something for us.
Project manager within South Eastern Trust, based in the emergency department. Prior to this, I was patient flow coordinator within the Ulster Hospital. The last few months have been quite a challenge for all of the staff, not just nurses. 2020 being the year of the nurse, we've already started the year off with the strike action. Then we had the increased workload within our departments and increased service demand. And then, of course, we had the pandemic. So if anything has been highlighted through all of this is the resilience of the staff, not just nursing staff, but the multidisciplinary team. How long we can sustain this for is probably questionable. Staff are tiring already, and a large portion of the staff that we have had within the trust and within the department were due to retire or move on to other areas, but that was all put on hold just to meet the demands that were within the acute sector, which is where I'm based. Society is very much challenged at the minute by the ageing workforce, and yes, we have seen a large number of those people within the workforce reach retirement age. They've selflessly stayed on to help us, and we're phenomenally grateful for that, but that has led to the real risk now that we will have a surge in retirements and gaps in employment. That coupled with the profession themselves, a lot of our staff have underlying health conditions, have family at home who are shielding, and they have no option but to either leave the career that they have stepped into just for the safety and well-being of their family. I think as well, though, a positive that's come out of this is that the public, other disciplinaries, other teams have seen what nursing entails, the day-to-day challenges that we face within the profession and throughout the wider health service. We can hope that this will also help in attract a new generation of nurses into the health service. Ways we learn to communicate with each other. Our emergency department had to be split into a green zone and a red zone just to manage the different acuity and the different type of patients that were presenting to the department. We had to then find new ways of working and communicating with each other. We used Vocera to be able to speak to staff that were in the green zone and couldn't go to the red zone, and vice versa. We were able to call specific members of the team, so the nurses in charge for specific areas, different types of multidisciplinary team members, and without that our job would have been a lot difficult. Another thing that we would have done is we had pressure meetings 3 times a day within the hospital, looking at bed availability, acuity in the ward, staffing levels, ICU capacity, and amongst other things. This had to change then to be done through a meeting platform and Zoom. It was beneficial in that it drew in a wider range of people from within the acute and community setting. So we definitely have a better way of working with across communities, as in acute, primary, secondary care, which I think will benefit us in the long run, that we've built up those relationships with areas that we wouldn't have necessarily been talking to before. The challenges that we're coming into within the next couple of months, everybody is aware of, and everybody will step up to the mark, as they always do, but we just have to acknowledge and stay strong for the staff, and be, you know, as leaders we have to be visible and be there for them to come to. Even if there's not a lot we can do to support them, at least they know that we're there, and they can acknowledge that we can acknowledge that there is concerns and worries amongst them. I think that's everything. I don't think there's anything else really I was going to talk about.
So apologies there for the stop-start on the video, but thanks very much to Cathy. That was great. Some really interesting points there. For example, the potential for a retirement bulge and just how tired staff are right now. Anyway, so last but not least by any means, we have Rhonda. So take it away.
Thank you, Steve. It's a real pleasure to be with you this morning and to talk about what we've experienced more globally with the pandemic, and also with managing and supporting nurses around the world. I was in the UK on business. I arrived in through Scotland on February the 19th. And frankly, when I'm working, I don't really pay attention to the news. I don't really watch the telly. I work. I prepare for the next meeting and the next day and the next presentation. And I actually left Heathrow on March the 5th. I had been in Northern Ireland and in Wales and in England. And I left Heathrow on March the 5th, and literally the entire world shut down on March the 8th. So it was, I re-entered the United States. I live in Austin, Texas, and I was stunned by what I saw. And immediately was on the phone with nurse colleagues that I work with, and my CNO colleagues around the United States, Australia, Canada, and was speaking actually to some in the UK to see how things were changing. It was just such a very quick ramp up that we were trying to figure out exactly how it started in the US. And actually, our first known documented case was January the 19th, just outside Seattle, Washington. A man had returned from Wuhan, China on January the 15th. He was feeling poorly. He went into a clinic, and actually it was a very intrepid nurse practitioner who recognized and diagnosed him. And so that began our journey really in the United States. But we're such a huge country, and we have 2 very wide open spaces where people enter the United States. The New York City rapidly ramped up. One of the things that I saw was, you know, the way our health system is structured is there's a competitive spirit, you know, among the hospitals. It's very, you know, it's everyone offers services and we sort of compound on each other. But what I saw was a remarkable and unique approach to CNOs working with each other, determining how to move patients through the system when there were not enough beds. And frankly, there were not enough beds. There were hospitals on the south end of Long Island that were 80% COVID. Eventually, they became 100% COVID patients because patients were just being moved around in the city. Patients that did not have COVID but need to be hospitalized were being transported upstate in New York. And then what we saw is that frequently they were having to turn boardrooms or non-functioning areas of the hospital into patient rooms. They had to put patients in beds. And so there was no nurse call. There was no ability for the patients to communicate with the nurses. We had a critical shortage of PPE. So nurses were needing to stay gowned. They were needing to stay in the area with the patients and not move out and contaminate, because there was no other PPE for them to don. And so what we did at Vocera was we managed to use one of our badges and just actually affix it to the bed, so the patients could call the nurse without having a head wall, without having a call system, but the nurses and the patients could all stay in contact with each other, all hands-free. And that's what's been so critical for us is, you know, when I talk about technology making a huge difference, the ability to wear a communication device under a gown that you don't have to hold to your face, you don't have to talk as far as, you know, you don't have to know numbers, you don't have to know names. You can just say, okay, Vocera, and it wakes up and you can say, call the cardiologist on call or call respiratory therapy. It may be that I came on at 7 p.m. and I have no idea who the respiratory therapist is covering my unit, but the software will know. So when I talk about technology really making a difference in a crisis like that, this is what we've seen. It's been, when you talk about nurses becoming fatigued, it's not usually the big things, it's always the repetitive gnats around your ankles, if you will. It's just the things like, you know, where is the call sheet? Because we don't like to make multiple iterations of call sheets, because then we have to update all of them. We'll just do one, but everybody's looking for the same piece of paper all day long or the same information. And so what we do at Vocera is enable that information to be available to everyone, hands-free. We don't have to know names, we don't have to know numbers. And I always say it's like our smartphone now. I mean, I have 2 grown children and I couldn't tell you their phone numbers, but I know I just tap their name, you know, and I can get hold of them anytime, day or night. So that's what we try to replicate. It's what is easy in our personal life, what is easy to facilitate our lives. That's what we do with technology. We have seen hotspots all around the United States. We are seeing it sort of has moved in from the coast to central US to the Midwest. We see areas up and into Chicago now who are managing it very differently because of the way we're structured. Our states manage slightly differently. So then we see the progression of the virus move through. We have committed to enabling nurses to communicate with families, to communicate with the patients and all of those who are involved in the entire experience. You know, we've had a screening of patients move outside the hospital. It's actually in the parking lot. You know, they've set up tents, and Vocera has been able to support all of that communication. And I would say, you know, when I listen to my esteemed colleagues talk about the challenges they had, communication is the backbone of all of that. So what we try to do is just facilitate to connect both documentation, live urgent conversations, all of that through a communication structure. I talk a lot about cognitive burden and how the burden of having to remember these things, having to remember numbers, having to remember names, having to remember information is what can wear on clinicians over time, where it makes their job harder than it needs to be. It makes their job, I always say it's like wearing the tread off of a tire. You know, you just roll it and roll it and roll it, and eventually you're like, I can't, I'm full, I can't do this anymore. And so what we try to do is just remove that burden of memory, remove that burden of having to carry information that is necessary, but it takes up bandwidth that it doesn't need to take up in our memory and in our thinking space. So we can support all of that across the entities. We do believe that communication should be a singular technology solution rather than bleeps for one group and phones, mobile phones for another group, and then landline phones for another group. You're really not solving the problem. And so when you decide, look, we're going to make everybody mobile because their job is mobile. You look at how do people work, and you give them tools that fit within the context of their work. And so, you know, bleeps are obsolete. One of my colleagues always tells this story. He's a pharmacist, and he said, every time I go to the airport and I start unloading my pockets and I put a pager in the bin, security says to me, oh, you must work in healthcare. Because literally no one else uses a pager or a bleep. And it's so funny to me. So when Sean tells that story, I always smile. We all need to move forward. And for me, when I say reduce the burden for nurses, make it an easier place to work, technology can play a huge role because we can smooth out the rough edges. We can take the burden when it gets too heavy to carry. Just think about all of the things you do all day long with just simply your smartphone, and how it eases your day, how it eases your burden, your memory. I doubt any one of you woke up this morning and said, I know exactly where I'm supposed to be, all the numbers I'm going to call, you know, what I have to do all day long. You rely on your technology to give you that information. So it only makes sense that we would do the same for these nurses doing this very, very important job. The consultants, everyone, in taking care of us. They are our last line of defense against the pandemic. Nurses have done extraordinary work through this time. You know, there's no surgical procedure for this. There's been some trial medications, and we all are waiting anxiously for the results of these trials. It has been predominantly extraordinary nursing care that has brought these patients through this life-altering experience. It has been nursing care that has connected families who are having to remain distant from their loved ones while they're in the hospital. And it has been nurses who have held each other up, who have extended their caring to the families and to the patients and their expertise. And so I think that we're waiting for the other shoe to fall with the second round of this. And I think that making decisions that make it easier for them to come to work, to make it easier for them to do their job, is very important for us as nurse leaders, and to really be open to that conversation.
Muted, Steve.
You're muted, Steve.
Steve, you're still muted.
There you go.
Okay, hi again there. Sorry, I managed to mute myself, which is obviously an increasing challenge with today's society with Teams and Zoom and everything else. Anyway, what I was going to say was thank you very much to Rhonda. Now, I think Kathryn was jumping in there to tell me that I was muted, and thanks to her as well for that. Some really engaging information there on our from our speakers. As I said at the start, we'll now move to our question and answer section. I can see we've already had lots of questions coming in. First of all, I wanted to start off just with some quick overarching ones to get things going with our panelists, basically, and just touching on our overall themes that we started off the talk with. So I'm gonna kick off with, I said that they're quite big questions, but what are the key challenges around nurse wellbeing with the current crisis? I'm gonna aim that one at Kathryn first, and then we'll come to Rhonda second.
So I think they're huge challenges actually. So when we started to enter the first wave, I think there was a feeling of we don't know what we're going into, a bit of sort of blitz spirit in terms of we'll get through this together. I'm very, very concerned that people are not feeling like that now. They know what they're going into. And if it's anything like last time, it's going to be really, really difficult. So I think it's going to be very challenging for us. We had, as I said, 25% sickness levels before. We're planning for the same level of sickness levels again, but we really need to continue to support our staff through our psychological services to make sure they're getting the right sort of support to enable them to keep coming to work and to keep looking after our patients and to keep looking after themselves, really.
Great, thank you, Kathryn. Rhonda, have you got anything to add on that one, maybe from an international perspective?
Yeah, I think that we are very concerned that we're going to have a critical nursing shortage. Many of the nurses who are at close to retirement age anyway have said, I'm not hanging around for another round of this. And I was facilitating a nurse executive roundtable, and they were all saying that that is their greatest concern, that we're not going to have the staff that we need in the years to come. So as always, we've been through this before. We've been through critical nursing shortages before, but to to begin the work through advocacy and allocating funds and working through our governmental process to increase funding for nursing schools and faculty and that sort of thing. That's definitely that's a long-term plan. It's definitely something that we have to look at in the short term as we move forward.
Great, fantastic. Thank you, Rhonda. And just sticking with your kind self, obviously we've been talking about technology a bit there. And you obviously done a report on all of this as well that you've written. So you obviously think that technology has a real role here to support resilience and improve nurse wellbeing. So could you just explain why that is?
I think I talk a lot about cognitive burden. I've been published on that topic in multiple forums. Cognitive burden is a concept that came from education. It's the wondering of why can 40 or 50 people sit in a classroom hearing the same instructor, getting the same information in the same way, and a certain percentage will fail the class, a certain percentage will have top marks in the class. It's all has to do with how we manage certain core competencies or core characteristics of cognitive burden. And one of those things is that, what do we have in our personal lives that adds to our work? Some of us have special needs children, or some of us have aging parents, or there's financial concerns, or the extreme worry now of bringing something home to our family that we have contracted at work. All of those, that adds to it. And then you come into with already carrying these burdens. I call it the rucksack that you can't take off. It's the thing that goes with you everywhere. And then you come to work and you have this very congested, sometimes chaotic environment that you work in. I mean, hospitals are basically founded in chaos theory, which is that theory that even though everything is moving like this and sometimes unpredictable, there is a certain order to it. It does exist. And then you add to that, how do I respond to that? So what I have really focused on is doing research and studying nurses' response to technology. Because it's counterintuitive to think that technology can make your work better. I think the thinking is technology makes it more congested. Technology makes it harder for me to do, because now not only do I have to do this, this, and this, I have to go back and do this. And I think that that's really just how we set systems up. We are reluctant to let go of paper-based documentation and reluctant to go to full digital documentation. So it makes it very challenging, because sometimes we require them to do both. And I come from the world of, we have to trust the technology. We have to enable the nurses to be on the go. There's nothing about a mobile phone that is mobile except the user I'm the one who's mobile. Not that if I lay that phone down, it doesn't go anywhere till I pick it up again. And so I think that we have to embrace the notion that nurses are extremely mobile. And so we have to enable them to function as in the context of their work. And of course, that's what we always focus on. And I think it's a conversation that nurse executives have to get comfortable with.
Fantastic. Kathryn, anything to add on the question of technology? Obviously, you mentioned that you've adopted it more quickly and, you know, from an NHS point of view.
So I think what we have learned very quickly is technology allowed us to allow people to go home to work, for example, which has been really useful. I think that we are very keen to get to an electronic record, and we are working towards that. But some of the things that in some of the enablers for that, some of the systems, we have actually been able to put quite a lot of pressure on the companies to help us with that because of COVID during this period of time. So we're very hopeful that we will move to more of a digitally enhanced way of caring for patients than we do at the moment. We absolutely see other organisations benefiting from the use of technology, and that's what we absolutely are aiming to work towards. Yeah.
Fantastic, thank you. So we've had plenty of questions in. I'm gonna kick off with a selection of those. Sorry, Kathryn, I'm going to stick with you because I think this one is kind of aimed at something that you said in your presentation. In fact, we've had about 3 or 4 questions all asking for a bit more information on exactly what a wellbeing room or a wobble room consists of. So could you describe what your wellbeing room is?
Absolutely. So I think lots of organisations put these in. We as I said, very quickly realised that people were very stressed, very anxious, and needed to have some space away from the workplace, really. So our HR team actually set up our wellbeing rooms, and we had them on both sites. And they were our lecture theatres, actually, because obviously we had stopped education. So very quickly they bought in some new furniture, some soft furnishings, some tables, put in some refreshments, made it into a much more of a pleasant seating area. Those areas were manned 18 hours a day by people from our OD team, who were able to support people with counselling if necessary, support. They obviously were trained in doing that, and also point people in the direction of other support that they might need to have if they required it. So things like the chaplaincy service, we had online support services, and if people wanted to have a phone call and have a conversation, they could also do that, and that was also available through the wellbeing rooms. We also had things like jigsaw puzzles, which were enormously popular. So we had tables with great big jigsaw puzzles on, and people came in, did some pieces, and then went away. It just was a place where people could come and relax away from the workforce, be with their friends, and at that time obviously we didn't have to social distance in quite the same way, so they were closer to their friends than they are now. Now of course we have to be 2 metres apart, so our wellbeing rooms look very different because we can't have very many people in those wellbeing rooms because of social distancing. But it's really an area where it was more homely, it was relaxing. It was where we had people available to support people who were crying, people who had experienced really difficult things, and to point them in the direction of further support if they needed that. I noticed that some of the questions were asking about ongoing support and how are we doing that, and how have we done risk assessments. We have absolutely done that. 50% of our workforce is BAME, so all of the risk assessments associated with the BAME population have been completed, and we've put in additional support for those staff where appropriate, so we've moved them if we needed to do that. So really we've tried, the wellbeing rooms and the wellbeing hubs and the wobble rooms were a centre for us to support people, but it also went out into the rest of the organisation. But because they've been so popular, we're going to keep them on a permanent basis.
Great, thank you, Kathryn. Yeah, I was going to ask about the BAME question, but you've covered it nicely there. Maybe Rhonda could take this one to put you on the spot a bit. With someone's asked, a very practical one, is what tools and techniques do you recommend to staff to be trained in to support their ongoing well-being? Is that anything you've come across?
Absolutely. I think that first of all, to celebrate the big things and the small things. We've had many hospitals in the US who played songs as patients were discharged from a long stay and a recovery from COVID. We've also honored the staff, certainly have done extraordinary measures to honor the staff and their work. But I think that over time, even that gets like, what I know you appreciate me, but really what can you do about the fact that I've worked X amount of days in a row, or the shifts are very difficult or they're very long. I think that when we first started this, there was we were baking lots of cupcakes and we were sending a lot of pizzas, and we were doing a lot of things that we thought, you know, were really, and it was very important. But over time, people were saying, look, I don't want another slice of pizza. I would really like to be able to talk to someone about what I've experienced. I would really like to be able to build programs or build ongoing resources that can support me in what I know is still to come and what I have to work through now. And so I think that we have worked really hard to create those safe places to have those conversations. One thing that we've had to deal with quite a bit here is that the increased emotional distress that comes from social isolation has exacerbated depression, addiction, all of those things that really cause emergency responses, but people are staying out of the emergency room. So what would have been something that could have been easily managed then becomes a crisis. And so what we're trying to do now is ensure that everyone understands it's still okay to come to the hospital. It's still okay for the staff to treat and work with you. And so, and we've had an increase in violence against healthcare workers because of the stress of families being separated, of patients coming in crisis. So all of those things that have caused us to sort of shift our culture in nursing to, instead of saying, oh, this is your patient, you just do whatever you have to do, to saying, probably this isn't the way we need to do this. Probably let's talk about this. Let's start talking about violence against healthcare workers. And is there any other job in the world where we would just shrug and say, well, that's part of being a nurse? There's not. There's no other job that you can go to work and it's okay to be hit or yelled at or spit on or all of those things. So we're finally lifting that culture to say, what do we do and what tools and resources do we have? The other thing that I've seen that I think comes out of this is nurses have a bias to action. You know, it's like we're not a group of people who sit and wring our hands and wait for it to all get better. You know, we want to fix it. That's why we're nurses, because we want to fix it, whatever it is. And I have seen nurses be so incredibly innovative and entrepreneurial through this time to be able to say, look, this whole thing is controlling me and I'm exhausted with it. So I'm going to control it. And I'm going to say, this doesn't work anymore to have to document this here, 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 and here. So I'm going to say we have to get rid of this. And that's what they've done. Are we doing this treatment or this assessment or this rounding just because we're ticking a box or because it makes a difference? And nurses are finally stepping up and saying, this does nothing for the improvement and well-being of the patient. All it does is create work for me. And so I think on the positive side, we're seeing a real shift in how nurses own their profession, how they own their practice. And they're being very, very innovative in what works best. We have actually are starting to see, because proning for these patients is critically important, and nurses have created policies and are now being published, and we're starting to talk about what have they done that has really improved that experience and the outcomes with proning. So that's the positive side of this, is nurses are able to manage their resiliency and give themselves a mental break by feeling like they have more control of the environment than the environment sitting on top of them.
Great, thank you very much. Kathryn, I'm coming to you again. I've had couple of questions in asking about support for specific groups. I don't know whether you can possibly answer it, probably expand a bit on your presentation. One is talking about staff who are working from home, so presumably therefore maybe either quarantined or in just isolation, and also students. Of course, we had in the UK we had a lot of students who volunteered to help out while their studies were paused and things like that.
Okay, so thank you. I think there's a couple of bits about working from home. There's one group of people who can take their work home. So we had a number of clinical nurse specialists who had to go home and were shielding, but they actually were able to do most of their work from home. And we have a very impressive story of our blood transfusion nurse managing a major hemorrhage from her kitchen because she was able to use the technology to do that. So I think that's one way, and a sort of extreme way of doing it. Most of them were running their clinics virtually from home if they needed to. And what we did was, for the people who were working at home, they perhaps ran all of the virtual clinics, whereas the people working in the hospital were doing the more practical things within the hospital. A number of senior nurses were working from home, and they were able to manage their teams, and they did daily huddles and that sort of thing with their teams during that period of time. We also had our staff nurses and things who were shielding and unable to come to work. So with those people, we made sure that they were able to stay in touch and involved and doing things like policies and procedures, which was the stuff that people absolutely hate doing. But I can't tell you how excited people were to be asked to do it whilst they were shielding and at home, because they felt like they were making a contribution. And it was really important to make sure that people felt that they were making a contribution. All of the teams were encouraged to maintain regular contact with their teams whilst they were at home. So they all had weekly calls and weekly team meetings. Everybody was included, so whether you were on site or off site. So I think for that group of people, we supported them with our new laptops and things. We deployed 1,200 laptops in a very quick period of time, which again was quite an achievement for us, really. If administrative staff and things, it was much easier for those staff to be working from home, and we sent a lot of equipment home for staff, so they took their computers home and their monitors home and that sort of thing, so that they could be supported from home. But we were very conscious for things like International Nurses Day. We made sure that the boxes we made up for the nurses went to all of the nurses who were working from home, so they still continued to feel like they were part of our team, really. And we've been really careful about bringing those people back into the organisation, because when you've been shielding, you didn't even know how to get into the hospital, because the front door is not the front door anymore, and you have to wear a mask, and you have to wash your hands, and you have to take your temperature, and you can only walk one way around the hospital, and you can't walk in some bits of it because it's green. So all of that is really difficult. So we were quite clear that as people came back into the organisation, they had an induction so that they could understand how to get into the organisation and how to work in their organisation. And that was facilitated by their team members, really. So we've got most people back. Those people who are quarantined, we have a couple of ways of managing that, actually. So people can either work from home, so that's really easy if you're somebody who can do a lot of work from your laptop. But if you're a healthcare assistant or a staff nurse and your work is practically based, what we've said to people is if you would like to take that time, and we will pay you for that time, but then you pay us back the shifts over the next 6 months. So if during that period of time you would normally work 6 days, you pay us back 6 shifts over that period of time. Or you can take it as annual leave, or you can take it as unpaid leave. And for us, that's very important, because we have lots of people who will need to quarantine because they need to visit their families overseas. So they will want to go overseas to visit their families. So we need to plan that when they come back, we have a way of not disadvantaging them financially, because obviously they need to see their families, particularly in the Philippines, India, that sort of thing, for their mental well-being. So that's really important. And then in terms of students, we work very closely with our local universities normally. So for us, this was an extension of the normal work that we would do with them. So we had about 100 student nurses who came to work with us. We worked very closely with their university, and we provided and supported facilities for them to do their online training with us whilst they were with us. And we paid them for all of those days. So they worked with us for 80% of the time, 20% of the time they continued to do their university work, but we paid them for 100% of the time. So we have supported our student nurses. They're now going back to university, finishing off their placements and coming back into us. So we have recruited nearly all of the people that chose to come and work with us as students. So we're really pleased about that.
Fantastic, thank you. Really great answer there. Just last couple of questions. I've got my eye on the clock. This is a great one, I think. It's come in anonymously, but I'll fire it away. What would the panel members do differently, given any hindsight? So, sorry, Rhonda, I'll pick on you with that one, as Kathryn has just been speaking.
All right, let me quickly gather my thoughts.
Yeah.
I think that if I could start this all over, it would be to focus on how do we put together programs up front that allow nurses to have a place for a mental resting. One of the things that we did was embed moment of mindfulness into our software. So if a nurse is feeling overwhelmed, they can just ask Vocera to play like the Calm app, if you're familiar with that, where it plays back restful information, allows you to have a moment of mindfulness, of affirmation, those sort of things when folks are feeling overwhelmed. We focus on helping them feel safer. I think that we did iterate very, very quickly to support the needs of the customer. When in my role, I actually respond to the customer. When the customer tells me I have this issue and I need something adjusted, or I need engineering to iterate on this software or do that, I will say that Vocera did a remarkable job in responding to the hospitals all across the country who were having to do what we called pop-up beds. The pop-up beds being those that were just being put in closed down units or boardrooms or whatever. So I think looking back, I would probably be a lot more proactive of saying this is going to come your way, and it's always based on lessons learned. And so let's get in front of this. Let's start looking at how do we create mental resting space for the nurses, rather than just because when it first started hitting, we just work. You know, we just had to run to catch up with it. But I think that I would be much more structured in allowing that.
Thank you. It's a tough question, so you know, I put you on the spot there. So, Kathryn, anything from your point of view that you might look to have done differently, or I guess you have the chance to now, if we're unfortunately heading into some more tricky months ahead?
So I think it's about the planning. I think it really builds on what Rhonda says. You know, it hit us hard. It hit us much faster than we thought it was going to, and we thought we had a plan to know what we were supposed to do. And in fact, NHS London were running a simulation event whilst the patients were flooding through the door. So the whole thing was too late. So for us now, we're trying to get on the front foot and have been for some time planning for when the second wave arrives. The problem is we don't know when it's going to arrive. We think we're seeing a rise now. We think the severity is increasing, you know, over the last couple of days. So we are putting those plans into action, but we don't know whether it is the second wave or whether it's just a blip. So we're putting those in place. We think we're better informed, and we have better plans now. And I wish I'd had a year to plan for it. If you reflect on the things that people have done during particularly that first 12 weeks, it was extraordinary. And nobody would believe you could have done that. And the ability to have planned that over a year's period of time would have been absolutely great, because I think across the country, people have done phenomenal things in very, very difficult times.
Absolutely, I absolutely second that. I mean, yeah, the nursing professions, the legacy from this, if there is a positive one, it's been amazing. So basically, yeah, I think we're pretty much out of time now. So thank you, everyone, especially those of you who submitted a question. Sorry if we didn't get around to yours. I tried to collate them together as much as possible. And thank you very much to our speakers, Kathryn, Cathy, and Rhonda, and again to Vocera Communications for sponsoring this webinar. We've recorded it, so you'll be able to watch it back if you would like to. And thank you very much, and goodbye. Enjoy the rest of your day. Thank you.
Thank you.